Most people choose a career because they want to make a difference, and I'm no exception. So as a bedside nurse, I found I could make a difference to individual patients' lives and experiences. And when I became a manager and a director, I discovered that I could make a difference also to the work life and the safety and health of employees. For 32 years, I worked in healthcare. I couldn't always find the solutions, and I couldn't always find ways to evaluate what I had done and figure out if I'd actually made a difference. So, as Shervelyn indicated, I decided to come back to UBC to see if I could contribute to healthcare in a different way from outside the system. One of the big issues facing healthcare right now is violence against healthcare workers from the people they care for. This violence can be intentional or unintentional. It can be due to frustration, it can be due to disease, dementia, any number of things where people are struggling and don't get their needs met, or in some way come into conflict in the health system. And healthcare workers are at the front line. Healthcare workers have a greater risk of injury from violence than police officers, correctional, or security guards. It's also highly underreported, so that even though we have high reports of injuries and violence, it's actually just a fraction of what's actually going on. The violence itself can be verbal, it can be physical, and the stuff that hits the headlines is usually quite graphic, but it is damaging psychologically as well as physically. And it's also damaging our healthcare system as we take away resources that we could be using to care for patients, and we lose staff due to burnout and things. So the main intervention that's come forward to try to address violence has actually been to educate staff. And that's to look at how can we identify early, how can we prevent, how can we mitigate, manage, and report violence to fix the system. One of the issues in that is that it can be quite hard with education to figure out how things make a difference and if they do. These are complex systems. At its base, an education system gives a resource, and particularly in-service education. So we're going to give you training, we're going to give you knowledge, we're going to expect something happen, and you're going to apply it directly in your workforce, in your workplace. What we do realize is that just doesn't always happen. Most of our programs work for some, don't work for others, work for even one individual in one circumstance, but not individuals in another. It's something that I was used to calling spray and pray, which meant that we would create a program, figure out who we could give it to, hope if we sprayed large enough it would stick to someone and something might work. The reality is we actually don't always know what's working and what isn't. When we're going to evaluate a program, it's really what method you're going to use, as we've heard even from Kate, is it's going to depend on what your question is, what kind of program you're evaluating, and what you want to do with the information. And often with things like a violence prevention program, I don't want to just know did it work or not because I'm packing up my bags and leaving. I actually want to do something about the program to figure out how to fix it. And sometimes when all I'm doing is measuring numbers, such as incidents of reports of violence, I'm not going to know whether the program was effective and I've got more increased incidents of reporting because they're reporting finally, or because the actual incidents of violence have increased. So it doesn't always give me the story. Most workplaces, healthcare system probably in particular, are open systems. We can't control all the various variables. Multiple variables are contributing to why there is violence, and the same number of variables are contributing whether a violence prevention program is going to be successful or not, and have the outcomes that we're hoping for. So instead of seeing this as a major challenge and giving up because you figure this can never be done, there's an opportunity to actually acknowledge the complexity and explore rather than control the differences, and focus on the program beyond being in isolation, but in context of the situation that you're actually putting it in and wanting to evaluate it in. The evaluation technique that I want to be applying to my research is something called a Realist Evaluation. Developed in the United Kingdom for use in social and health programs, it actually starts to explore whom does the program work for, in what circumstances, why, and how. It recognizes that things change, and it allows us to start to tell the story in a different way. The realist perspective is that we see the world in two ways. We do have a shared way we see the world, where we may have the same understanding, but we also have our own experiences and our own perceptions, values, beliefs, and reasoning. That means our experience will be separate. So I may have the same education as the nurse beside me, and I may not apply the same things she will. So if the knowledge and training comes to an individual, whether it's in the situation of learning or whether it's when they go to apply it, the reasoning in their head is going to change whether or not they choose to take action to whether prevent the violence or report it or any of the other actions the education's meant to get people to start doing that they might not be doing already. If we apply that to reporting of violence, because we know that's a critical underreporting, if I'm in a context or situation where every time violence has ever been reported, nothing happens, it's a big black hole, nobody supports me, I don't hear back, I'm likely to be cynical about the next time I'm going to report. And you can give me all the education in the world, I'm probably not going to report that. A realist evaluation is all about theory. You start with theory, you focus on theory, and unlike a general interview, you might actually you're asking people for their opinions on the theory. So it is cycles of theory testing the data because we're looking for what is likely to occur in that shared space where we might see the world together. Where are patterns that we can actually use to inform how we change our programs? This is what a realist theory might look like, and that if staff support each other, they might feel safer and they might actually be willing to try de-escalating violence, where if they were in an environment where staff were not there to support them, they might not want to take that risk. So my research is going to look at conducting an evaluation of the Provincial Violence Prevention Program across 3 health authorities in emergency departments in BC, using interviews, focus groups, and looking at documentation, and hoping to inform both the violence prevention education as well as program. So violence is a serious issue in healthcare, it's international, and I'm hoping that by taking a new approach to evaluating the program, we can make a difference to evaluating violence and also demonstrate a new evaluation tool that might work for other social and health programs.